So in the mid-19th century, there was this prominent American physician named Samuel Cartwright. And he observed this phenomenon among enslaved African populations in the American South.
Right.
He noticed that many of them repeatedly attempted to flee captivity. And, rather than concluding that human beings just naturally desire freedom, he approached this through the lens of, well, what he thought was objective medical science at the time.
Which is just horrifying in retrospect.
Exactly. He invented a formal psychiatric diagnosis for them. He called it drapetomania, literally, the disease of running away.
Wow.
And his prescribed, peer-reviewed medical treatment for this mental illness, whipping them into compliance.
It is a devastating piece of medical history. And the thing is, Cartwright wasn't some fringe practitioner, He was highly respected.
Right, he was mainstream.
Completely mainstream. Even earlier, Benjamin Rush, the man who is still widely referred to as the father of American psychiatry, he actually taught his medical students that having black skin was a congenital disease.
The disease. Just skin color is a disease.
Yeah, a form of mild leprosy that he termed negritude. And the cure for this alleged pathology was, according to his medical writings, to become white.
It's hard to even wrap your head around. But welcome to this deep dive. You are listening to an exploration of one of the most vital, challenging, and frankly paradigm-shifting areas of modern medicine.
We are looking squarely at how the medical gaze, the way clinicians see, define, and treat mental illness is completely, inextricably bound to the society in which that clinician lives.
Today, we are grounding our discussion at the Transcultural Psychiatry chapter of Kaplan and Sadok's comprehensive textbook of psychiatry.
Spot on.
And our mission here is to build mental models that will fundamentally strengthen your clinical reasoning, especially if you are a trainee or registrar preparing to navigate a deeply diverse patient population.
Because if we don't understand the history you just described, if we dismiss Cartwright and Rush as merely racist men of their time rather than recognizing them as practitioners whose clinical reasoning was perfectly aligned with their dominant culture, we are doomed to repeat those structural errors today.
Absolutely.
We really have to look at psychiatry not just as a biological science, but as the study of how the brain, the mind, and human experience interact within a specific cultural matrix. And crucially, how that process can go wrong.
Right. I was actually trying to conceptualize how we bridge the biological brain with this abstract idea of culture. And I thought, well, think about a smartphone.
Okay, like this? Go on.
When a phone starts glitching, like apps are crashing, the screen is freezing, our first instinct is to examine the hardware.
Naturally.
We check the battery, we look for a cracked microchip, we assume something physical is broken.
And that is the default biomedical model, isn't it? We look for the broken neurotransmitter, the abnormal functional MRI scan, the genetic vulnerability. We're always looking for the tangible defect.
Right. But anyone in IT will tell you that sometimes the hardware is flawless. The battery is perfect. The processor is absolutely fine. The problem is the operating system.
Ah, yes.
The software.
Exactly. It's the invisible code running in the background, processing all the inputs, interpreting the data, and telling the hardware how to behave. If there's a bug in the software, you can take that phone apart with a microscope and you will never find the problem.
That is brilliant.
So if the human brain is the hardware, culture is the operating system.
That is the perfect foundation for our discussion. You really cannot debug the operating system by looking at the RAM. Culture is that invisible code that processes our experiences.
Right. It tells us what things mean.
Exactly. It tells us what a sensation means. It dictates how we should react to loss, and it completely defines what constitutes a normal trajectory through life. In psychiatry, attempting to treat the mind without understanding the culture is a profound clinical error.
Because you're missing the whole picture.
You might temporarily mask a symptom with a pill, but you are completely misinterpreting the machine. And we are swimming in this invisible code constantly. I think when we talk about culture in a clinical sense, we aren't just talking about, the food a patient eats or the language they speak or the holidays they celebrate.
No, it's far deeper than that.
The text moves culture away from this vague idea of tradition into a highly systemic framework, doesn't it?
It does. The textbook highlights that culture is a complex, multi-layered construct. It breaks it down into 8 key characteristics, actually. First, it isn't innate biology, it is entirely learned.
Right, you aren't born with it.
Exactly. It's a group process, but it's also transgenerational, meaning it's passed down. But crucially for clinical practice, culture relies on a set of agreed-upon symbols and meanings.
This is like a shared language, even beyond actual spoken words.
Yes. It acts as a template for future behaviors, preparing a group to account for novel situations. And it is constantly changing, too. It isn't just subjective feelings. Either it is expressed objectively in our societal structures.
Like our institutions and laws.
Quite. Our institutions, our legal frameworks, and most importantly for us, our healthcare systems.
Which brings us to a massive systemic blind spot in global psychiatry. Because if culture is the operating system, we really have to ask, who wrote the code for the DSM-5?
That is the million-dollar question.
Who determined the baseline for normal human psychology? The text brings up the concept of the weird problem, which is an acronym coined by researchers like Joseph Henrich.
The weird problem is an absolutely essential critique for any clinician to grasp. WEIRD stands for Western, Educated, Industrialized, Rich, and Democratic.
Weird.
Right. For over a century, the vast majority of foundational psychological research, the studies that establish our baseline understanding of memory, visual perception, moral reasoning, all the developmental milestones, that was all conducted almost exclusively on weird populations.
We aren't even talking about a broad cross-section of weird societies, are we? Historically, we are talking about a very specific convenience sample.
Mostly university students?
Yeah, white, middle-class undergraduate students at North American or European universities participating in studies for, like, course credit.
Yes, mostly 19-year-old undergrads.
No.
And the staggering revelation of cross-cultural psychology is that when you map global data, these weird groups are not the universal human baseline.
They aren't.
Not at all. In fact, they are statistical outliers.
Wait, really? The baseline we use is an outlier?
Exactly. For example, if you look at basic visual perception, like the famous Miller-Lyer illusion.
Oh, that's the one where two lines of identical length appear different because of the direction of the arrows at the ends, right?
That's the one. Weird populations are highly susceptible to that illusion. They see the lines as different length, but many non-weird populations globally do not. They see them accurately as the same length.
Oh, wow. Why is that?
It turns out that growing up in a highly industrialized environment with carpentered corners, right angles everywhere, literally alters your visual processing.
But wait, I can hear a skeptical listener pushing back here. Visual illusions are one thing. But surely profound mental illness like severe depression or schizophrenia is biological.
That's the common pushback, yes.
I mean, a broken leg is a broken leg, whether you're in London, Lagos, or Kyoto.
Yeah.
Isn't a neurodevelopmental disorder still a neurodevelopmental disorder? Aren't we risking throwing out all of medical science if we say everything is culturally constructed?
That is the trap of extreme cultural relativism, and the textbook navigates this very carefully. We are not saying the neurobiology isn't real.
Okay, good.
The genetic vulnerabilities and the neurochemical shifts are absolutely real. But the expression of that biology, the trajectory of the illness, the way the patient interprets their suffering, and the way society responds to it, that is entirely dictated by the operating system.
So if we build our entire diagnostic manual based on an outlier group, well, that's like designing a universal medical standard for treating sunburns based solely on how people with bright red hair and extremely fair skin react to the sun.
That is a phenomenal analogy. Yes, it goes even deeper than that, actually. You wouldn't just be treating patients poorly, you would be pathologizing their natural biology as a defect.
Because they don't match the weird baseline.
Exactly. If your manual says 5 minutes in the sun causes severe blistering, and the patient with high melanin comes in after an hour in the sun with no blisters, a strict, unquestioning clinician might write in the chart, patient is exhibiting an abnormal, blunted dermal response. Suspect systemic dysfunction.
Oh, man. So you are pathologizing health because your baseline is skewed.
Precisely. And that makes the evolution of cultural frameworks in clinical care so incredibly vital. We can't just be aware of other cultures. The text tracks how this field has had to mature rapidly over the decades.
Oh, because we started with cultural competence, which honestly sounds great on paper.
It was a necessary first step. Cultural competence is broadly defined as the capacity to function effectively while taking cultural factors into consideration.
Which makes sense.
It does. But as the text notes, it has a major clinical pitfall. When it is taught poorly, it essentially becomes a curriculum of stereotypes.
Right. I remember seeing this in medical school. It turns into a checklist. A medical student gets taught, patients from culture X believe Y, so you must do Z.
Exactly. It implies that culture is static, monolithic, and can be mastered by just reading a pamphlet.
Like learning a recipe.
Yes. And it completely ignores individual variation, intersecting identities, and the power dynamic between the doctor and the patient. This limitation led to the development of a much more rigorous framework, which is cultural safety.
Now, this originated in New Zealand, didn't it? With nurses working alongside the indigenous Maori population.
It did. And the paradigm shift here is profound. Cultural safety shifts the locus of power entirely.
How so?
Instead of the clinician declaring, I am culturally competent in your background, the focus is entirely on whether the patient feels safe receiving care within that specific clinical encounter.
Oh, that's a huge difference.
It is. It demands that the clinician continuously reflects on their own systemic biases and the historical power differentials in the room.
So it's not about memorizing Maori traditions. It's about the clinician understanding how the history of colonization and medical marginalization might make a Maori patient inherently distrustful of a Western medical institution.
Exactly.
And then actively working to dismantle that threat in the clinic.
Precisely. And that naturally scales up to the next concept outlined in the text, which is structural competence.
Structural competence. Okay, break that down for us.
This framework trains physicians to recognize that the inequalities they see in the clinic, the much higher rates of severe distress in certain minority populations, are not biological destiny, nor are they cultural deficits.
They are just weaker.
No, they are the downstream effects of social determinants of health. It is zoning laws, economic policies, systemic racism, and resource allocation.
Which introduces this really humbling idea of structural humility. A psychiatrist has to realize they cannot prescribe away systemic poverty.
They really can't.
You can't treat a housing crisis with an SSRI.
You cannot. Which leads to the most active, demanding framework discussed in the text, anti-oppressive practice.
Anti-oppressive practice. That sounds very active.
It is. This isn't just about understanding the patient's context. It is about actively working to disrupt all forms of oppression, racism, classism, ableism, genderism.
So the clinician isn't just an observer anymore.
Exactly. It requires the clinician to act as an advocate, to unlearn their own privilege, and to pursue equity and collective liberation alongside their patients.
Let's talk about that word equity, because it gets thrown around constantly in public discourse, often interchangeably with equality. But clinically, they dictate very, very different treatment plans.
They do, and mixing them up is dangerous. Equality is the principle of treating everyone exactly the same, providing identical resources across the board.
It sounds fair on the surface.
It does, but equity is the true principle of fairness. It recognizes that because of historical and ongoing systems of oppression, patients do not start from the same baseline. If you treat a highly resourced, dominant culture patient with generational wealth exactly the same as a newly arrived refugee facing housing instability, you are not being fair. You are actively perpetuating the existing inequality.
Because the refugee needs different support.
Exactly. Equity means providing the specific, differentiated resources necessary for both patients to achieve optimal health outcomes.
And when you look at the demographic shifts happening right now globally, understanding that equity is not equality is going to be the defining challenge of clinical practice for anyone listening to this deep dive.
Without a doubt.
The text notes that by 2060, immigrants will make up over 17% of the U.S. population alone. That is nearly 70 million people. But when we talk about this demographic, we have to separate two terms that get conflated constantly: race and ethnicity.
It is a critical distinction to make. From a purely biological and genetic standpoint, race is an utter fiction.
Just totally made up.
Yes. There are no discrete biological boundaries between socially constructed racial groups. However, and this is key from a sociological and clinical standpoint, the process of racialization is very real.
Racialization, meaning the act of categorizing people.
Exactly. Grouping people based on arbitrary physical traits and attaching hierarchical value to those traits is a brutal structural reality that affects patient health.
So race is an externally imposed category, historically weaponized for exclusion or exploitation.
Yes, that's exactly it. Ethnicity, on the other hand, is generally a self-assigned or community-assigned identity rooted in shared culture, ancestry, geography, language, or history.
But both are highly fluid, right?
Incredibly fluid. If you look at national censuses, the absurdity of treating these categories as biological facts becomes really obvious.
The comparison the text makes between the U.S., Canada, and the U.K. censuses is fascinating.
Yeah.
Like in the U.S., Hispanic or Latino is considered an ethnicity separate from race.
Right.
But in Canada, the census revolves around the concept of visible minorities, a term the UN has actually criticized for being too imprecise to effectively track socioeconomic gaps.
Because it's so broad.
Exactly. Canada groups together incredibly disparate linguistic and geographic populations simply based on their visibility against a white majority.
And if you look at the UK, the 2021 census breaks white down explicitly into English, Welsh, Scottish, Northern, Irish, and crucially, Gypsy or Irish traveler.
Oh, wow.
Yes. That category highlights a highly specific ethnic minority with distinct health disparities in the UK, but that group wouldn't even register as a distinct census option in North America. These are entirely localized, socially negotiated categories.
But the text is very clear on one thing. Just because they are social constructs doesn't mean we stop collecting data on them, right?
Absolutely not. Because racism and ethnic discrimination are real, these constructs dictate a patient's social reality.
Right, the impact is real.
If we adopt a colorblind approach and stop collecting disaggregated data, we instantly blind ourselves to the massive structural disparities in access to care, misdiagnosis rates, and clinical outcomes.
Let's look at one of those clinical outcomes regarding migration, because it completely defies common sense. The text explores the healthy immigrant paradox.
Ah, yes. This is a very counterintuitive phenomenon.
If you asked the average person, they would assume the monumental stress of uprooting your life, leaving your home country, and integrating into a foreign society would immediately tank your physical and mental health.
That is the logical assumption, yes. But robust epidemiological data frequently shows the exact opposite.
Really?
Yes, newly arrived immigrants often present with significantly better physical and mental health profiles than the native-born population of the receiving country.
Okay, let's create a scenario to understand the mechanism here. Let's say a highly trained civil engineer from Lagos, Nigeria, emigrates to London. Why is her baseline health initially higher than the average Londoners?
It comes down to a powerful selection bias. The individuals who possess the financial resources, the physical stamina, the psychological resilience, and the sheer administrative capability to successfully navigate the grueling process of international migration, they are fundamentally a highly select, robust cohort.
That makes sense. It takes a lot of strength to move continents.
Exactly. Furthermore, receiving nations like the UK or the US often impose stringent health and credential requirements, so you have a highly resilient, healthy individual arriving.
But the paradox has a second, much darker half. The text notes that this health advantage consistently erodes over time. 10 years later, our engineer's health profile has plummeted. What happens in that decade?
This is where the clinician must really focus. The erosion is the result of acculturative stress. Let us continue with your hypothetical engineer. She arrives in London, but she discovers her Nigerian engineering credentials are not recognized by the local licensing boards.
Well, that happens all the time, so she has to find other work.
Yes. To feed her family, she begins driving a minicab or working night shifts as a security guard.
So she suffers an immediate, profound loss of social status.
A massive loss. She goes from being a respected professional in her community to occupying a marginalized lower-class position in a new society. Add to that the daily friction of microaggressions, the isolation from her extended kinship network, and the language or accent barriers.
And what about her family?
Well, furthermore, her children will likely acculturate to British society much faster than she will.
Which creates a dangerous intergenerational gap. The children become the cultural translators for the parents, navigating the doctors and the schools.
Yes.
Which completely inverts the traditional family hierarchy.
Precisely. That role reversal generates immense psychosocial stress within the family unit. Over a decade, that chronic, low-grade systemic stress fundamentally alters her allostatic load, eroding her initial health advantage until she is at a higher risk for depression and anxiety than the native-born population.
And that's voluntary economic migration. The clinical picture shifts radically when we talk about involuntary migrants, refugees, and asylum seekers. I think it's crucial we don't just lump all migrants together.
We absolutely cannot. The clinical assessment of a refugee requires parsing distinct temporal phases of trauma.
Okay, what are the phases?
First, you have the pre-migration phase, surviving a war zone, witnessing deliberate killings, enduring torture, or facing starvation.
Just unimaginable horror.
Then there is the transit trauma of the flight itself, human trafficking, exploitation, surviving in squalid refugee camps for years.
Because the naive assumption is you've made it to a safe country, the trauma is over, now you can heal.
And that assumption is clinically dangerous. Post-migration is rarely a sudden arrival at safety. It is often characterized by years of agonizing legal uncertainty.
Right, the waiting.
Imagine surviving a civil war only to spend 3 years living in temporary hotel accommodation in Croydon, legally forbidden from working, waiting every single day for a letter from the Home Office that might deport you back to the war zone.
Living in constant fear.
The psychological friction of that temporal shift from acute survival mode to stagnant bureaucratic limbo is where severe psychiatric pathology often solidifies.
The textbook cites a devastating real-world example of this. The Bhutanese refugee population resettled in the United States. Between 2008 and 2012, around 90,000 arrived.
Yes.
The data showed a depression prevalence of 21% and a staggering suicide rate of 21.5 per 100,000.
And if you look closely at the specific risk factors identified for that population, they illustrate exactly what we are discussing.
Who was at the highest risk?
The highest risk was among those who were traditionally the family providers, who self-reported poor health, and who were illiterate in their native language.
So if you are illiterate in your native language, the prospect of ever mastering a new language to navigate a foreign bureaucracy is almost zero.
Almost zero, yes.
You are permanently stripped of your identity as a provider. It's an absolute dead end.
It leads to profound demoralization, which is a key driver of those suicide statistics. Clinicians must understand that the pathology isn't just a flashback to the war zone. It is the current, ongoing, structural entrapment.
This brings us to another highly specific mechanism of trauma detailed in the text, indigenous historical trauma, or IHT.
Yeah.
And the book makes it very clear this isn't just another term for PTSD.
No, it is a distinct, vital clinical concept, particularly when working with First Nations, Aboriginal, Maori, or Native American populations.
How does it differ from standard trauma?
IHT has 4 core distinguishing features. First, it is colonial in origin. Second, it is collective in impact. It targeted entire nations and cultures, not just individuals.
Okay, colonial and collective. What's the third?
Third, it is cumulative over time. It compounds across multiple adverse events like forced relocation, the banning of languages, and the traumatic removal of children into residential schools.
And the fourth feature?
The cross-generational transmission of risk.
It makes sense if you think about it structurally. IHT isn't just a ghost haunting a family. It's a foundational crack in a building.
I like that.
If the architects of colonization compromise the ground floor of a community by destroying their economy and outlawing their healing rituals, then the second floor is built slightly off-kilter.
Yes.
That means the third floor is carrying uneven weight, even if the storm that caused the initial crack happened a century ago. The vulnerability is structural.
That is an excellent way to conceptualize it. The transmission is both psychosocial through disrupted parenting models and persistent socioeconomic marginalization and potentially epigenetic, as chronic stress literally alters gene expression across generations.
But the textbook strongly cautions against a deficit-only model, doesn't it?
Yes,
Yeah.
very strongly, because that just becomes another form of pathologizing a whole population.
Right. Just saying, your whole culture is traumatized.
Exactly. The literature highlights profound resilience. While the foundation has a crack, integrating traditional healing practices, reclaiming language, and participating in tribal ceremonies acts as a binding agent. It reinforces the concrete,
So acknowledging it is actually healing.
validating the historical truth of IHT within a clinical setting can be deeply cathartic and empowering for the patient.
So we've explored these massive systemic forces, the weird problem, structural racism, migration, historical trauma. Let's pull the camera right down into the consultation room.
Let's do it.
How does all of this invisible water manifest when a patient is sitting across from you? Because a Western-trained clinician is waiting for the patient to say, I feel sad, my energy is low, I am experiencing anhedonia.
Which, again, assumes a weird baseline.
Right.
The DSM-5-TR provides a critical framework to handle this called cultural concepts of distress. It breaks the patient's presentation into 3 distinct categories. The first is cultural idioms of distress.
So if I understand this correctly, an idiom of distress isn't the disease itself, it's the vocabulary the patient uses to signal they need help.
Yes.
It's the difference between saying, I meet the criteria for major depression, and saying, my heart is heavy.
Exactly. It is the culturally patterned way of communicating suffering. Every culture has them. In the UK, saying I am gutted or I am completely shattered are culturally accepted idioms that convey a mix of physical and emotional exhaustion.
But when a patient from a non-Western background uses a somatic idiom expressing emotional pain through the physical body, like severe stomach pain, headaches, or dizziness, Western medicine often handles it terribly.
Terribly.
The old psychoanalytic literature used to call Somatization a primitive defense mechanism.
Yes, and that view is heavily criticized in the current text as inherently ethnocentric. It is rooted in Cartesian dualism.
Cartesian dualism reminds what that is.
It's the philosophical insistence, deeply embedded in Western thought, that the mind and the body are completely separate entities.
Oh.
If you strictly divide the objective disease of the body from the subjective illness of the mind, then a patient presenting with physical symptoms for an emotional problem looks like they're either faking it or lacking psychological insight.
But that dualism is the cultural quirk.
Exactly. For the vast majority of human cultures globally, experiencing distress holistically through the metaphor of the body is the normative baseline.
So it's not primitive at all, it's just different.
Right. If a patient comes into A&E complaining of crushing chest pain and profound fatigue, and the cardiac workup is totally clear, a registrar might dismissively write them off as functional or supratentorial.
Which completely invalidates the patient's suffering.
It does. The clinician misses the opportunity to validate the somatic pain, which is very real to the patient, while gently pivoting to explore the psychosocial stressors driving it.
The text gives some incredibly poetic, vivid examples of these idioms from refugee populations. For instance, Oromo refugees describing their distress as burning from the inside, or Somali patients describing having air in the brain or feeling not dead or alive.
And this is where clinical translation becomes dangerous. If a psychiatrist hears air in the brain and simply ticks the box for major depressive disorder on the electronic health record, they have fundamentally erased vital clinical data.
Because air in the brain carries a specific context that MDD doesn't.
Yes. A fascinating study highlighted in the text showed that refugees were significantly more willing to report their symptoms and engage in treatment when they were allowed to contextualize their distress within their political reality.
So the idiom contains the politics.
Exactly. The burning from the inside isn't a random neurotransmitter misfire. It is inextricably linked to the history of their flight, the loss of their homeland, and their current marginalization.
And if you ignore that,
stripping that political and social context away to force it into a sterile Western diagnostic code dehumanizes the patient and usually results in poor treatment adherence.
this connects perfectly to how a patient views their own agency in the world. The text references Sue and Sue's matrix on worldviews, specifically looking at the locus of control and the locus of responsibility.
This is a phenomenal tool for clinical formulation. Locus of control refers to whether an individual believes they have the power to shape outcomes in their life.
Right.
Locus of responsibility refers to who is blamed for failures or credited for successes.
So the dominant Western weird culture operates heavily on an internal control, internal responsibility worldview, the ICIR mindset.
Yes, the ultimate individualistic framework.
You are the master of your fate, you pull yourself up by your bootstraps, and if you fail, it is your personal flaw.
Exactly. But imagine a patient whose entire lived experience has been dictated by systemic oppression. Perhaps they're a refugee, or they've grown up in deep generational poverty facing structural racism.
Great.
They might hold an external control, external responsibility worldview ECR.
Meaning they accurately perceive that massive external forces control their destiny and that the system is responsible for their marginalization.
Yes. Now, bring that ECR patient into a clinic with an ICIR psychiatrist. The psychiatrist asks about their goals, and the patient exhibits passivity. They seem apathetic, unwilling to take charge of their recovery.
Because they feel the system controls the outcome anyway.
Right. The psychiatrist observes this and writes down, patient exhibits flattened affect, lack of motivation, and anhedonia, high likelihood of clinical depression.
But the patient might not be clinically depressed at all. They might just be executing a highly calibrated survival strategy.
Exactly.
If you live in a system that is rigged against you, keeping a low profile, exhibiting learned helplessness, and not drawing attention to yourself is how you survive.
That is the crux of the issue. The clinician is pathologizing a rational protective mechanism because they are misinterpreting it through their own cultural lens.
Let's look at the other two categories in the DSM-5-TR framework. We had cultural idioms of distress. Then we have cultural explanations.
Cultural explanations represent the patient's explanatory model. It is their answer to the question, why is this happening to me?
Like, what is the root cause?
Yes. Is my suffering caused by a chemical imbalance in my brain, a curse from a jealous neighbor, a breakdown in my familial duties, or a punishment from God? Understanding this is critical because it dictates what kind of treatment the patient will accept.
And finally, cultural syndromes. These are clusters of symptoms recognized as specific illnesses within a culture.
Yes, the DSM-5-TR lists several. Susto in Latin American cultures, which is a profound distress attributed to a frightening event that causes the soul to temporarily leave the body.
Wow, okay.
Or hikikomori in Japan, a syndrome of severe, prolonged social withdrawal often seen in young men. Or ataque de nervios, which involves intense emotional upset, shouting, and feeling a loss of control, typically triggered by a stressful family event.
So when we combine all of this, the idioms, the locus of control, the explanations, conduct a psychiatric assessment.
Very.
Let's talk about the culturally competent assessment. Because the standard mental status exam, the MSE, which is the absolute bedrock of psychiatry, suddenly looks like a minefield of cultural bias.
It is a complete minefield. The textbook highlights the engagement triad, communication, empathic understanding, and rapport. And communication is where things break down immediately, specifically regarding high context versus low context cultures.
And Western medical training is extremely low context.
Very low context. The expectation is that all meaning is explicitly articulated in the spoken words. If you don't say it out loud, it didn't happen.
Right.
But much of the world relies on high context communication, where the vast majority of the message is encoded in the environment, the power dynamics, and the unspoken physical cues.
So in a clinical setting, a high-context patient is reading the entire room before the doctor even says hello.
Oh, absolutely.
They're looking at the doctor's posture, the degrees on the wall, the way the receptionist spoke to them, the physical distance between the chairs.
Exactly. And if the Western clinician is ignoring that context, staring at their computer screen, waiting for the patient to explicitly state their symptoms, they are going to conclude the patient is guarded or poorly communicative.
When in reality, the patient is communicating volumes, but the clinician is deaf to that frequency.
Spot on.
Let's look at a specific high-stakes example of how this ruins an MSE. Assessing perception. Hallucinations.
The textbook gives a crucial warning here. Imagine a patient from a non-Western background whose parent recently died. During the assessment, they mention that they frequently hear their deceased parent offering them encouraging words, or they feel their physical presence in the room.
In a strict, low-context, Western biomedical framework, hearing a voice without an external stimulus is an auditory hallucination, period.
Yes.
You tick the box for perceptual disturbance, and you start thinking about psychotic disorders or severe psychotic depression.
But cross-cultural research demonstrates that maintaining a continuing active bond with the deceased, including hearing their voice or feeling their presence, is a highly normative, healthy, culturally patterned manifestation of bereavement in many societies globally.
So how does a clinician differentiate between healthy cultural bereavement and the onset of actual schizophrenia?
By exploring the context and the distress, does the experience terrify the patient or is it comforting? Is it aligned with the beliefs of their broader community?
Right, does it fit in?
Yes. Does it impair their daily functioning or does it help them cope with grief? You cannot diagnose pathology based on the mere presence of the phenomenon. You must assess its function within the patient's cultural operating system.
To standardize this process, the DSM-5-TR provides the outline for cultural formulation, the OCF, and a practical tool called the Cultural Formulation Interview, the CFI.
The OCF demands the clinician assess 5 distinct areas. First, the cultural identity of the individual. Second, their cultural concepts of distress.
Which we just covered.
Right. Third, the psychosocial stressors and cultural features of vulnerability and resilience, essentially. What is their social network doing to help or hinder them? Fourth, the cultural features of the relationship between the individual and the clinician. And fifth, the overall cultural assessment to guide management.
Let's zoom in on that fourth point, the relationship between the clinician and the patient, because this is where transference and countertransference get intensely complicated by history.
It is arguably the most difficult aspect of transcultural psychiatry. Power imbalances in the clinic mirror historical power imbalances. A clinician from a dominant culture might unwittingly oppress a minority patient by subtly invalidating their worldview.
Or conversely, the text notes the phenomenon of historical guilt.
Oh yes, this happens quite a bit.
A dominant culture clinician might become so hyper-aware of historical injustices that they become paralyzed. They overcompensate, refuse to challenge the patient, and ultimately fail to provide necessary structured care because they are terrified of appearing oppressive.
Which is ultimately an abandonment of the patient. When these dynamics are unexamined, the clinician usually ends up projecting their frustration onto the patient.
How does that look in the notes?
This is where you see charts filled with punitive labels. The patient is lacking insight, they are non-compliant, passive-aggressive, or enmeshed with their family.
Wow.
Those labels often describe the clinician's failure to navigate a cultural disconnect rather than the patient's actual pathology.
To prevent that, clinicians use the CFI, which is a set of 16 core questions. What I find brilliant about the CFI is the phrasing. It doesn't ask, what are your psychiatric symptoms?
No, it is much broader.
It asks, what brings you here today?
Yeah.
And crucially, question number 2 is, what troubles you most about your problem?
What troubles you most shifts the entire clinical focus. A patient might be experiencing visual hallucinations. The Western doctor assumes the hallucination is the primary problem. But when asked what troubles them most, the patient might say, because of what I am seeing, my community believes I am cursed and my daughter's engagement has been broken off.
So the primary distress is the social ostracization, not the perceptual disturbance itself.
Exactly. If the psychiatrist prescribes an antipsychotic that stops the visions but completely ignores the fact that the family is still socially ruined, the treatment has failed the patient. The CFI forces the clinician to align their treatment goals with the patient's definition of the problem.
Which brings us to the final hurdle, management and psychotherapy. Once we have formulated the problem culturally, can we actually use Western psychotherapeutic models like CBT or psychoanalysis on non-Western patients?
It is possible, but it requires deconstructing what psychotherapy actually does. The textbook uses a brilliant 3-tiered model to explain this trans-theoretical, meta-theoretical, and intra-theoretical.
The trans-theoretical level relies on Jerome Frank's model of healing. And Frank basically argues that all therapy, everywhere in the world, is fundamentally the same mechanism.
Frank strips away the specific psychological theories. Whether you are a Freudian psychoanalyst on the Upper East Side of Manhattan or a traditional shamanic healer in a rural village, the underlying structure is identical.
Really?
Identical. Yes. It is a culturally sanctioned ritual designed to combat demoralization. It requires an emotionally charged relationship with the helping person. It takes place in a designated healing setting, and it relies on a shared rationale or myth about why the patient is suffering.
So the active ingredient isn't necessarily the cognitive restructuring, it's the ritual of hope and the therapeutic alliance.
Exactly.
But when we drop down to the meta-theoretical level of the underlying philosophy of the therapy, that's where Western models can actively harm non-Western patients.
Because Western therapies are saturated with Western philosophical values. Cognitive behavioral therapy is deeply rooted in Greek Stoicism and empiricism. Classical psychoanalysis is rooted in the Victorian era. These therapies implicitly champion the independent self.
Right. The goal of Western therapy is usually autonomy. We teach patients to set rigid boundaries, to strengthen their ego, to individuate from their parents, and to challenge their own internal cognitive errors so they can function independently.
But what if the patient comes from a culture influenced by Asian philosophies or many indigenous frameworks which conceptualize the self as profoundly interdependent?
In that worldview, you literally cannot separate your identity from your family, your ancestors, or your community.
Exactly. The goal of healing in an interdependent framework is often to relinquish self-centered attachments and harmonize with the social network.
Ah, I see the conflict.
If a Western therapist tries to force an interdependent patient to set hard boundaries and cut off a demanding family member, the therapist isn't empowering the patient, they're demanding the patient commit cultural suicide. It will rupture the therapeutic alliance instantly.
The text also introduces a fascinating way to analyze the feel of therapy using the concepts of yin and yang. We evaluate therapy on time, locus, and activity.
Looking at the activity dimension is particularly useful. Therapy can be conceptualized as active and directive identifying problems, challenging thoughts, executing behavioral experiments. In Taoist terms, this is yang energy, masculine, bright, forceful, outwardly directed.
Which perfectly describes standard CBT.
It does. But therapy can also be passive. And passive here does not mean weak or ineffective.
Right.
It means the quiet power of tranquility, acceptance, observing without reacting, yielding. This is yin energy, dark, feminine, receptive, inwardly directed. Mindfulness-based therapies, rooted in Buddhist traditions, heavily utilize yin approaches.
So if a patient is culturally primed to view suffering as something to be endured with quiet acceptance, a yin approach, and the therapist insists on aggressive yang cognitive restructuring, the patient will likely drop out of treatment.
There is a fundamental mismatch in the operating systems. The clinician must have the flexibility to adapt the modality to the patient's cultural expectations.
And this need for adaptation becomes an absolute crisis when we look at the global scale of mental health care. The section on global mental health, or GMH, presents some of the most grim statistics in all of medicine.
The treatment gap is catastrophic. The text notes that in low and middle-income countries, LMICs, up to 89% of individuals diagnosed with severe conditions like schizophrenia receive absolutely no evidence-based treatment.
89%.
Yeah.
That is staggering. And the downstream effects of that are brutal, deepened poverty, severe stigma, human rights abuses, and significantly increased mortality.
Yes.
But we can't solve this by just building Western-style psychiatric hospitals in every rural village.
Yeah.
We don't have the resources, and as we've established, exporting Western models wholesale is culturally dangerous.
Which is why the cornerstone strategy of GMH is task shifting or task sharing.
Let's break that down, because the textbook highlights a phenomenal success story in Zimbabwe called the Friendship Bench Project. It is the perfect synthesis of everything we've talked about today.
Task shifting involves taking the delivery of psychosocial interventions away from highly specialized, scarce psychiatrists and training non-mental health specialists like lay community members, primary care nurses, or traditional healers to deliver them.
In Zimbabwe, they faced a massive treatment gap for depression and anxiety, but they didn't go in and try to teach the population about major depressive disorder.
No, they tapped into the local cultural idiom of distress.
Right.
They identified the local idiom kufunzisa, which translates from Shona as thinking too much. This is the culturally understood expression for the cluster of symptoms we might label depression or anxiety.
And who did they train to treat it? Not young medical students.
Yeah.
They trained community grandmothers.
Lay health workers, predominantly older women who already held significant cultural respect and authority within the community. They trained them to deliver a culturally adapted form of problem-solving therapy.
And how did they do it?
These grandmothers would sit on designated wooden benches situated in accessible clinic grounds, and community members could come and sit with them to discuss their kufunjisa.
It is brilliant. It uses the engagement triad perfectly. The communication is culturally congruent. The sitting a bench outside a clinic is accessible and non-stigmatizing, and the results were staggering.
The clinical trials showed that the Friendship Bench intervention led to significantly greater improvements in symptoms of depression and anxiety compared to standard enhanced psychiatric care.
Wow.
It was so remarkably effective and so structurally robust that the model has now been exported and adapted for use in cities like New York.
It proves that when you align the treatment with the cultural operating system, the efficacy skyrockets.
Yeah.
But the text closes this section with a very serious warning about the global mental health movement as a whole, the risk of epistemic injustice.
Epistemic injustice is a critical concept to end on. While the GMH movement is driven by a moral imperative to close the treatment gap, there is a profound danger of intellectual colonialism.
Intellectual colonialism.
Yes. If Western researchers and institutions export the DSM-5 globally, treating it as the singular objective truth of human suffering, they risk completely overriding rich, local, indigenous pathways of healing.
We risk erasing diverse cultural expressions of distress, replacing thousands of nuanced idioms with a standardized Western checklist.
Exactly. We must balance the universal human right to mental health care with a deep, structural respect for local cultural realities. We must ensure we are not simply imposing a Western operating system onto the rest of the globe and calling it science.
This has been an incredibly dense journey. We've moved from the history of racism and diagnostic framing through the profound structural impacts of migration and historical trauma, all the way to the granular details of how a patient's body speaks through cultural idioms in a clinic.
We covered a lot of ground.
We did. To leave you with a final provocative thought to mull over, we readily accept that syndromes like Susto in Latin America or hikikomori in Japan are genuine culturally bound ways of experiencing distress. But if the DSM-5 is, as the text suggests, an evolving cultural document written by a specific demographic, is it possible that conditions like anorexia nervosa, or even the highly specific criteria we use to diagnose major depressive disorder, are actually just Western cultural syndromes?
That is a fascinating question.
Are we, in the highly industrialized West, Simply experiencing our own specific idioms of distress, slapping a Latin or clinical name on them, and falsely declaring them to be objective universal science.
It is a question that requires continuous, rigorous reflection from every clinician who holds the power to diagnose.
Absolutely. Now, to help cement some of the core concepts and mechanisms we've explored, we are going to run through a learning reinforcement with some single best answer questions based directly on the textbook chapter. I will read the question, I will pause for a beat so you can formulate your answer, and then our expert will provide the correct answer and the clinical rationale.
That's good.
Question 1, focusing on concepts. Which framework of culturally informed care originated specifically from nurses working alongside the indigenous Maori population in New Zealand and shifts the focus away from the clinician's knowledge toward the historical oppression and power differentials experienced by the patient? Let's take a beat.
The answer is cultural safety. Unlike cultural competence, which risks becoming a checklist of stereotypes, cultural safety prioritizes the patient's subjective feeling of safety within the healthcare system and demands the clinician critically reflect on their own systemic biases and power.
Question 2, focusing on mechanisms. According to Sue and Sue's worldview dimensions, how might a patient with an external control and external responsibility, an EC or worldview, present in a Western clinical setting, and how might this be misdiagnosed? Think about it.
They may exhibit passivity, apathy, or a lack of forward planning. A Western clinician might misdiagnose this as anhedonia, flattened affect, or clinical depression. In reality, this presentation often reflects a survival strategy, keeping a low profile to navigate systemic barriers and oppression when the patient accurately perceives they lack systemic control.
Question 3, back to concepts. Which of the following represents the distinguishing core features of indigenous historical trauma, or IHT, separating it from general psychological trauma?
The distinguishing core features of IHT are that it is cross-generational in the transmission of risk and vulnerability, it is colonial in origin, and it is collective in impact, meaning it targeted and cumulatively affected an entire community or nation over time, rather than just an individual.
Question 4 on clinical reasoning. A Somali refugee patient describes their deep emotional distress by stating they have air in the brain. Under the DSM-5-TR cultural concepts of distress framework, what does this specific phrase represent?
This represents a cultural idiom of distress. It is a culturally patterned, common vocabulary used to communicate suffering to others. Stripping away this idiom to force a Western diagnostic label often alienates the patient and removes vital political and social context from their clinical formulation.
Question 5, another clinical reasoning scenario. During a mental status examination, a patient with limited fluency in the dominant language mentions that since their father died, they frequently hear his voice offering them encouraging words. What is the most appropriate initial clinical reasoning step?
The clinician must evaluate whether this experience is a normative, culturally patterned manifestation of bereavement within the patient's specific cultural group. Maintaining an active perceptual bond with the deceased is normative in many cultures and must be ruled out before prematurely diagnosing a perceptual disturbance like a psychotic hallucination.
Question 6, looking at management. In the meta-theoretical view of psychotherapy, Western therapies like CBT often emphasize the independent self. Which philosophical framework aligns with mindfulness-based therapies that conceptualize the self as profoundly interdependent?
Buddhism and Asian philosophies. These frameworks focus on relinquishing self-centered attachments and recognizing that the self cannot be separated from one's social network, family, or ancestors. Imposing an independent therapeutic goal on an interdependent patient can rupture the therapeutic alliance.
And finally, question 7, on global mental health. To address the massive psychiatric treatment gap in low-income countries, which is estimated to be up to 89%, global mental health initiatives often utilize a strategy where non-mental health specialists deliver psychosocial interventions. What is this strategy called?
This strategy is called task shifting or task sharing. It involves training individuals like lay community members, such as the grandmothers in the Zimbabwean Friendship Bench Project, to deliver evidence-based, culturally adapted interventions.
Excellent. Thank you for joining us on this deep dive into the invisible operating system we all navigate. Here are the details of this episode.
Transcultural Psychiatry. Byline. Mental illness does not exist outside culture. It is expressed, understood, and treated within it.